All right, now let's talk about some other diagnostic criteria for VT. One of them is the Vericchia criteria.
In this video,
Many
I'm going
authors
to talk about the Brugada criteria for ventricular tachycardia or VT. Now, ventricular tachycardia can be quite difficult to diagnose from the conventional ECG. So we use the Brugada criteria, which is very highly sensitive and specific. Its sensitivity can be as high as 98%. And the specificity, sometimes it can be as high as 97%, which is fantastic. We can rule in and rule out with the Brugada criteria. So over the next few minutes, we'll talk about Brugada criteria. And at the end of this video, you will have a very good understanding about Brugada criteria, and you can use these tools for the diagnosis of VT. So let's set up some goals. So for the next few minutes, we'll talk about the ventricular tachycardia, which is a type of wide complex tachycardia. We'll talk about the Brugada criteria, what they are, how to interpret them. Of course, uh, after the diagnosis of VT, we'll touch base on the main goals, main diagnostic and management options. There are some of the controversies with regards to Brugada criteria, and we'll talk about that as well. So, broad complex tachycardia, it is a very complicated topic. We'll try to keep it as simple as possible. So let me show you one of the ECGs of a patient that we have seen a few months ago. So this was the patient, 72-year-old, who came with palpitation. And as you can see in this ECG that there is white QRS complexes and they are pretty regular. The ventricular rate is about 200 beats per minute. And there is a bit of right bundle block as well. So we have tried to diagnose what it is on the basis of ECG and the patient characteristics as well. And we found that this patient has got a VT and we treated as SARS. Patient ended up having one pacemaker, AICD, and he's doing well. So let's talk about the wide complex tachycardia. So any QRS complex which is more than 100 milliseconds is considered as wide complex, and if the ventricular rate is more than 110 beats per minute, we call it a VT or wide complex tachycardia, which is regular. Of course, 80% of the wide complex tachycardia is actually VT. So when we talk about wide complex tachycardia, mostly we talk about VT. Now, wide complex QRS, usually it happens because the origin of the QRS is in the ventricles, and it is multifactorial. The problem mostly is in the heart, but there are some other conditions like some toxicological cases or metabolic cases like hyperkalemia. They can also give rise to the wide complex tachycardia. Now let's focus on the various types of tachycardias. There are narrow complex and wide complex. So in case of wide complex, there can be regular and irregular. So usually we talk about 80% of the cases of the wide complex tachycardia is VT, but also it can be SVT with aberrant conduction. There can be ventricular pacing. There can be Wolff-Parkinson-White syndrome with the antidromic conduction. And of course, there can be some medications like tricyclic antidepressant and electrolyte abnormalities like hyperkalemia. They can cause this as well. In case of AVRT, patient can have antidromic conduction that can give you the regular tachycardia. In case of irregular tachycardia, the main things that we find is either it is an atrial fibrillation with aberrant conduction, or there can be atrial fibrillation with antegrade conduction through the accessory pathway. That can happen if the patient has got Wolff-Parkinson-White syndrome. Of course, patient can have polymorphic VT or torsades if the patient has got prolonged QTC. Ventricular fibrillation and antidromic AVRT, that also is considered some of the irregular tachycardias. Now, without getting into further details on these various topics, I've got a different video for that. Let's move to the diagnostic approach straight away. So there are different things that we can do for the diagnosis. Now, with regards to the ECG criteria, we'll focus on certain specific things. So let's get oriented with the diagrams. So this is the heart. This is the right atrium. This is the right ventricle here. This is the left atrium is here, and this is the left ventricle. This is the ascending aorta, and this is the superior vena cava, this is the inferior vena cava. With regards to the conduction system, we have got the SA node here, which is the pacemaker. It is generating cardiac impulse, and that goes through these interatrial pathways to the AV node. Now, AV node itself has got some refractory period, so all the cardiac impulses cannot straight away go to the ventricles. AV node works as a gatekeeper, so that it controls the passage of the cardiac impulses from the atria into the ventricles. So from the atrioventricular node, it goes to the atrioventricular bundle or bundle of His, then it goes to the right bundle branch and the left bundle branch and the Purkinje fibers and cardiac muscle. So normally, the SA node is producing cardiac impulse. It goes through the conduction system, and we get a nice narrow QRS complex. However, in case of the VT, the problem happens is that the cardiac impulse is generated in the ventricle. It may be here, it may be here, it may be here, and then there is usually a single focus. That is why it's called monomorphic ventricular tachycardia. When it generates, it remains within the ventricle. It does not go to the atria. So there is a little bit of what we call atrioventricular dissociation. The atrial activity, it remains within the atria, and the ventricular activity remains within the ventricle. There is no association between the atrial activity and ventricular activity. This is something called atrioventricular dissociation, which is, sorry about the spelling mistake, there should be an O there. So atrioventricular dissociation is very specific for the ventricular tachycardia. Now let's get into the animation. Now, as you can see here, the atrial activity, it remains mostly in the atria, but sometimes it actually manages to go to the ventricle. And that is when we get this something called the capture bit. There is a capture bit. So there is a P wave followed by a QRS complex, which is narrow complex. P wave followed by a QRS complex with a narrow complex. So these are capture bits, which is this wave here, it is going to the ventricle, and the QRS complex is normal QRS complex. If you carefully look at it, the cardiac impulse which is coming from the atria to the ventricle, and the cardiac activity which is going from the ventricle towards the upper part of the interventricular septum, they actually fuse together, and then we get a QRS complex which is a little broader than the normal QRS complex. This is called the fusion bit. And these are the ventricular ectopics, sorry, not the ventricular ectopics, these are the ventricular tachycardias. They are coming at a rate of about 150 beats per minute. And they have got pretty good concordance as well, because we cannot identify the R wave or S wave here. Now, this is the classic presentation. A few things here are important. Number one, no relationship between the atrial activity and ventricular activity. Number two, there can be some capture bit and there can be some fusion bit. If these are present, this is very diagnostic of ventricular tachycardia. Now let's show you some of the more ECGs. So this is lead V1 and this is in V5. If you carefully look at it, this is white QRS complex. This is coming at a rate of about 160 to 170 beats per minute, pretty regular. There is a little notch here, which actually is a P wave. There is another P wave here. There is another P wave here. There is another P wave here, another P wave here. There is no relationship between the P wave and the QRS complex. So that is classic atrioventricular dissociation. And if there is atrioventricular dissociation with a white complex tachycardia, this is VT until proven otherwise. Another good example here, there are actually two different types of things going on here. That is a P wave followed by a QRS complex. There is a P wave followed by a QRS complex. And PR interval that is pretty regular, pretty symmetrical on both sides. So this is a capture bit. This is a capture bit. And these are the ventricular tachycardia. But again, the P wave and QRS complex do not have any association with each other. So that is atrioventricular dissociation here. And these are the capture bits. So this patient has got a VT. Now, second important thing that we look at for the diagnosis of VT is the axis, northwest axis. So let's get oriented with this picture at first. So this is the heart. And if we consider 0 degree in the center of the heart, the 0 degree will be on this direction here. And then if we go clockwise, we will find that the 90 degree will be at AVF. And then there is 180 degree. And if we go this direction, that is AVR. If we go this direction, that is 270 degree. Minus 30 degree, that will be AVL. Any cardiac activity which goes towards the lead one will get a positive deflection. If the cardiac activity goes towards the AVF, we'll get a positive deflection here. And at the same time, we will get negative deflection in lead one if the cardiac activity goes this direction. If the cardiac activity goes in this direction, we'll get a negative deflection in case of AVF. So by looking at lead one and AVF, we can actually measure the axis. So this is how the whole 360 degree is completed. Now, very specific thing with the ventricular tachycardia is the northwest axis or extreme axis deviation. So basically, any cardiac axis which is between 180 degree and 270 degree, that is called northwest axis. Now, as you can realize that if the cardiac impulse is generated here near the apex in ventricular tachycardia, mostly it will go in this direction, which means in AVR there will be positive deflection. In lead 2, there will be negative deflection. In lead 1, there will be a negative deflection. So as you can see, the cardiac impulse is going at a very fast rate from here in this direction. And that is why there is a bit of negative deflection in lead 1. Similarly, if we look at AVF, it is going away from AVF, so there is a bit of negative deflection in AVF as well. If we look at the AVR, the cardiac impulse is going towards AVR, so we are not surprised that there is positive deflection in AVR. If we look at lead 2, the cardiac impulse is going away from lead 2, so there is a negative deflection here. If we look at lead 3, similarly, it will be predominantly it is negative deflection. So by looking at these mainly two leads, lead 1 and AVF, if both of them are negative predominantly, this patient has got an axis within here between between 130 degree to 270 degree, which is northwest axis. The northwest axis is usually we don't see in normal patients. The only time we will find it if the patient has got ventricular tachycardia. So very specific finding. Another very important characteristic feature of ventricular tachycardia is the width of the QRS complex. By definition, the QRS complex width that will be more than 100 milliseconds. But if there is width of the QRS complex more than 160 milliseconds, that is very, very suspicious that it could be VT. It can be something else. It can be hyperkalemia or toxicology, but usually the rate, ventricular rate should be less. In case of VT, in this patient, for example, the ventricular rate is almost 150 beats per minute. So this needs to be VT. Now, concordance is a very important concept. Concordance of the QRS complex in these chest leads, that is again very specific for diagnosis of VT. It can be positive complex, it can be positive upstroke of the QRS complex, so basically positive concordance, or it can be negative concordance. It depends on where the cardiac impulse is generating from. If the cardiac impulse is generating from somewhere at the posterior aspect of the ventricle, then probably it is positive deflection. If it is in the anterior aspect of the ventricle, then it will be negative deflection. So it can be positive concordance or negative concordance. So please don't get confused between concordance of the QRS complex and concordance of the ST segment. In left branch block, for example, if the QRS complex is upstroke, the ST segment will be down. That is discordance of the ST segment. In Scarborough criteria, we talk about concordance of the ST segment. But here in the VT, we are talking about concordance of the QRS complexes, which is completely different. Another important characteristic feature is the Brugada sign, which is a part of the Brugada criteria. So Brugada sign is from the beginning of the R wave to the nadir of the S wave. If this distance is more than 2.5 smaller square, which is 100 millisecond, this is Brugada sign. So this is the in the Brugada algorithm, this is number 2 characteristic feature. So in this particular ECG, we are finding two things. One is a Brugada sign. So from beginning of the QRS complex to the nadir of the S wave, here there is a distance of about 1, 2, 3, so 120 millisecond. Now, if you look at the downsloping part of the S wave, there is a little bit of a notch here. There is a bit of a notch. There is a bit of a notch. This is called Josephson sign. And this Josephson sign is also very, very specific with regards to the diagnosis of VT. Now, I can't see any rapid in this particular ECG. What I can see is there is a cardiac impulse which is generated probably from the left side of the heart, and it is giving rise to the appearance of a bit of a right bundle branch block appearance in the QRS complexes in the V1 lead. So because it is right bundle branch block, there is an upstroke followed by a little notch there, and there is a bit of downstroke. Now, someone with a lot of imagination may think of a rabbit here, and here we go. So this is a rabbit which has got a left rabbit here is little taller than the right, and I don't know how to correlate with this rabbit with the QRS complexes in the V1, but in the literature it's called the rabbit ear. Left rabbit ear taller, this is VT. Right rabbit ear taller, that is probably SVT with right bundle branch block. Now, the main topic today is the Brugada criteria. It has got a very high sensitivity, 98%, and a specificity of 97%. So we can rule out and we can rule in VT on the basis of the Brugada criteria. However, there are about 15 different studies so far on the Brugada criteria and the VT. The sensitivity and the specificity are probably not so high as it was originally advocated by the guys who have initially developed Brugada criteria, but still it is pretty good. So there are 4 steps. The first step is essentially the concordance. So basically in this particular ECG, if we look at V1, V2, V3, V4, V5, V6, there is no RS wave. All of the QRS complexes have got positive concordance. So if this is the baseline here, the QRS complex is white and it is above the baseline, and they look pretty much similar. And in V1, V2, V3, V4, V5, V6, similar. So all of them have got positive concordance. If there is a positive concordance or negative concordance from V1 to V6, this is VT. This is nothing else. This is VT. However, if we cannot find the concordance of the QRS complexes from V1 to V6, we go to the next step. And the next step is Brugada sign. We have already talked about Brugada sign. So Brugada sign is, for example, in this particular ECG, if we start from beginning of the QRS complex to the nadir of the S wave, that will be probably 4 smaller square, which is about 160 millisecond. Anything above 100 millisecond is the Brugada sign. If the Brugada sign is present, that is VT. So in this patient, this is VT. However, if the Brugada sign is absent, then we'll go for the next level. And the next level is the atrioventricular dissociation. I have already shown you some diagrams and some images. In this particular picture, as you can see here, there is a P wave here, P wave here, P wave is buried here, P wave is here, and there is a P wave. So P waves are coming pretty much actually regularly, but there is no relationship or association between the P wave and the QRS complex. So as I have shown you in the previous image, that the P wave is doing its activity within the atria, and the QRS complex that is doing its activity in the ventricle, and they don't have any relationship between them. And that is a very characteristic feature for VT. This is called atrioventricular dissociation. And in this image, as you can see, the atrial activity is in this bubble within the atria, and ventricular activity is within the ventricle in this bubble. and they're maintaining some social distancing between each other. Sometimes some of the cardiac impulses are managing to go to the ventricle and forming this fusion beat here and capture beats here. So this is very characteristic feature for VT. Now, if we do not find the atrioventricular dissociation, then we go for the morphological characteristics. Sometimes these morphological characteristics can be a little difficult to interpret, but it is actually not that difficult. Let me make it simple. So in this particular patient, what we are talking about with these morphological characteristic features is look at V1 and V6. In V1, if you see predominantly R wave, so only R wave, or there is a big R wave and a small Q wave, or there is a big R wave and a small S wave. So basically the RS ratio, that will be more than 1 in V1. In V6, the RS ratio will be less than 1. If that is the case, this is going to be VT. This is a morphological characteristics. This is a type of morphological characteristic. The other morphological characteristic is the width of the R wave in V1. If it is more than 30 milliseconds, or the from the second to the nadir of the S wave. So from here up to here, if the distance is more than 70 milliseconds, which is about 2 small squares, this is classic supposed to be a VT. In case of the nosed or slurred S wave like this one in V1, then that is also supposed to be a VT. So let me summarize Brugada criteria for the diagnosis of VT. There are 4 steps. In the first step, we look for the presence of concordance of the QRS complexes in the V1 to V6. This is also called the absence of the RS wave. If the RS wave is absent from the precordial leads, we call it concordance. Either it is a positive concordance or a negative concordance. If that is the case, this is VT. If it is absent, then we'll go for the step number 2, which is Brugada sign. Brugada sign is from the beginning of the R wave to the nadir of the S wave. If the distance is more than 100 milliseconds or 2.5 smaller square in a standard ECG, that is VT. If the Brugada sign is absent, we'll go for the step number 3, which is atrioventricular dissociation. If the atrioventricular dissociation is present, this is VT. If it is absent, we'll go for the step number 4, which is morphological characteristics. There are 2 types of morphological criteria. One is the RS wave in V1 more than 1 and RS wave less than 1 in V6. The other morphological criteria is the width of the R wave in V1 more than 30 milliseconds, or from the beginning of R wave to the S wave more than 70 milliseconds, or there is a slurred S wave in V1. So that is some morphological criteria. So on the basis of these different characteristic features, we can.
All right, now let's talk about some other diagnostic criteria for VT. One of them is the Ventricular criteria. Many authors and many researchers use this topic. Many clinicians use this criteria for the diagnosis of VT. So in case of Ventricular criteria, mainly what we look for is the QRS complexes in the lead AVR. And initially it might sound very complicated, but it's not that complicated. So the first thing we look at is in AVR, is there initial R wave? As you can realize from the previous images, that when the cardiac impulse goes from the lower part of the heart, like the apex of the heart, towards the AVR lead, there will be positive deflection, and that is the R wave. If the R wave is present in AVR, then that is going to be VT. So don't go any further. This is VT. If you find that the R wave, initial R wave is absent in AVR, then we'll go to the next step, which is look at the width of the Q wave or R wave in AVR. If it is more than 40 milliseconds, that means 1 smaller square, this is VT. And If you find that the initial R wave is absent and the width of the R wave or the Q wave is less than 40 millisecond, that is less than 1 smaller square, we'll go to the next step, which is there any negatively directed notch and mostly negative QRS complex in AVR? So if there is what it necessarily means is that the QRS complex is negative in AVR. That means from the upper part of the interventricular septum, the ventricular ectopic or the ventricular tachycardia is generated. So if that is the case, then it is VT. If not, we'll go for the last step, which is essentially based on the velocity. So if again in AVR, if the ventricular activation velocity divided by the terminal velocity is less than 17, that is VT. If all these four characteristic features are absent, then that is SVT with aberrant conduction or SVT with van der Waals block. So there are basically the four steps in AVR on the basis of which we can diagnose VT, and that is Verikay criteria. So let us summarize it once again so that we can understand it better. So there are four steps. Like Brugada criteria, the Verikay criteria have got four steps, yeah, but these are all based on AVR. So the first step is look at the initial R wave in AVR. If there is initial R wave in AVR, this is VT. If not, we'll go to the second step, which is width of the R wave or Q wave in AVR. If it is more than 1 smaller square or 40 millisecond, this is going to be VT. If not, we'll go for the third step, which is basically the negative notch or mostly negative QRS complex in AVR. So for example, it may be an S wave or it may be a Q wave. If that is the case, this is VT. If not, we'll go for the next step, which is based on the velocity, activation velocity divided by the terminal velocity. If it is less than 17, this is VT. Now, based on these four characteristic features, we can diagnose VT. However, if all these four characteristic features are absent, this is going to be SVT with aberrant conduction or van der Waals block. I hope you can understand what the Verikay criteria are, and it has got pretty good sensitivity and specificity in comparison to Brugada criteria. Now, some clinicians prefer to use another criteria, something called Griffiths criteria, which is uh, pretty similar with the steps that I have already talked about. So there are only two characteristic features. The first characteristic features is the morphology criteria. So just like Brugada criteria, step 4, you look at the lead 1, V1, and look at the V6. If there is mostly positive deflection in V1, so RS ratio will be more than 1, and in V6, RS ratio will be less than 1. This is going to be VT. The other morphology criteria is the width of the R wave, or from the R wave to S wave, nadir or the S wave. So that can also help us in the diagnosis of VT. If these criteria are absent, then we'll go for the atrioventricular dissociation. And we talked about atrioventricular dissociation, that the atria is doing its job and the ventricle is doing its job. There is no relationship between these two, and that is when we develop the atrioventricular dissociation, and that is VT. So these are the simple two characteristic features in case of Griffiths criteria. The first one is the morphology criteria on the basis of V1 and V6. So if the RS ratio is more than 1 in V1 and less than 1 in V6, that is VT. If not, we'll go for the atrioventricular dissociation, which is step 2. If the atrioventricular dissociation is present, this is VT. If not, this is SVT with aberrant conduction. So if we use this criteria, either we can use the conventional criteria or we can use the Brugada criteria or Verikay criteria or Griffiths criteria, life become a lot easier to confirm the diagnosis of VT, and we can appropriately manage that patient. I know it can be sometimes a little tricky to understand it, but if we go through the images and animations, I hope that it becomes easier for you. All right.
Do the diagnosis of VT. So when we talk about VT, we are talking about monomorphic VT, and monomorphic VT is that all the QRS complexes look like they are similar. They are same size, same shape, same morphology, and if this is present in the precordial leads from V6, so V1 to V6, this is classic presentation of VT. Now let's do some exercise. So this is a patient who is presenting with palpitation, and we are trying to interpret what is wrong with this patient. What we'll do is let's do the conventional characteristics and also the Brugada criteria. Now in this particular patient in V1 and V2, it can be a little tricky to identify which one is what. But if you look at the V3, V4, V5, and V6, I cannot identify, I cannot demonstrate which one is R wave and which one is S wave. So you can say that they have got negative concordance, which is basically the first criteria of Brugada. Even if you argue that there is a little R wave here and then followed by a big S wave, let's do the step number 2. Step number 2 is from beginning of R wave to the nadir of the S wave, the distance is about 3 smaller square, which is 120 millisecond. So this is VT. If we consider the third level, that is atrioventricular dissociation, I cannot see any R wave, so we cannot comment about our atrioventricular dissociation. With regards to the morphological pattern, again in V1 and V2, I can't comment about the morphological pattern. So I think based on the characteristic feature of presence of Brugada sign, I'll consider it as a VT. If we look at the conventional rules, then look at the axis. The axis here in lead 1, that is negative axis, and AVF negative. So basically this is a northwest axis, which is very characteristic feature for a VT. Here in lead 3, there is a notch in the downsloping part of the QRS complex, which is called the Josephson sign, as well as in lead 2, we have got Josephson sign. In AVF, we have got Josephson sign. These are characteristic features of VT. So this patient has got a VT. Let's look at another patient. Now, if we slowly go through these steps in a systematic way, then we will find that let's do the Brugada characteristics. So the first characteristic feature is the presence of concordance. In V1, there is a positive deflection of the QRS. There is a positive deflection in V2. There is a positive deflection in V3. However, in V4, V5, V6, there is negative deflection. So the concordance is absent. So there is some RS wave, especially in V6, for example. So we'll go to the next step. The next step is the Brugada sign. Again, if we start from beginning of R wave to the nadir of this wave, there are 4 smaller square, which is 160 millisecond, which means this patient has got a VT. And I cannot see any P wave, so I cannot comment about the atrioventricular dissociation. This is rhythm strip, which is taken actually after the 12 ECG has been done. So don't get confused between the these first 3 rows with the 4th row, please. So on the basis of the Brugada criteria, we can consider this as a VT. Even if we look at the morphological characteristics, in V1, there is predominantly R wave. And so RS ratio in V1 or V2 is more than 1. If we look at the V6, R, small r divided by big S wave, so that RS ratio is less than 1. So this is one of the morphological characteristics. The other morphological characteristic is width of the R wave. Here, that will be more than, it should be at least 3 smaller square, which is 120 millisecond. So anything more than 30 millisecond in V1, that is very diagnostic for VT as well. So let's look at another patient. So as you can see here, there is a wide complex tachycardia, and the ventricular rate is about 150 beats per minute and pretty regular. So we have got some options. It can be VT, it can be SVT with aberrant conduction, it can be atrial flutter with 2:1 block with right band aberrance block. Now let's use the Brugada criteria here. So at first, the first characteristic feature is the concordance of the QRS complexes. Now, in V1, that is positive, V2 positive, V3 probably negative, V4 negative, V3, V5 negative, and V6 that is negative as well. So there is no concordance. So we'll go to the step number 2. The step number 2 is a Brugada sign. So from the beginning of the R wave to the nadir of the S wave, there should be about 3 small square, which is 120 millisecond. So that is Brugada sign is present. So that should be VT. I can't see any obvious P waves, so I cannot comment about the atrioventricular dissociation in this particular ECG. Which is the morphological pattern, look at the V1. So there is a big R, small S wave. So the RS ratio will be more than 1. And in V6, there is a small R and big S. So the RS ratio will be less than 1. This is classic VT. Now let's do another patient. Now it can be quite difficult, this one, because of the ventricular ectopics, and there are two different types of ECG. On the left hand side we have got VT, on the right hand side we have some ventricular ectopics followed by some capture bits. Now as we have known from the conventional rule that if there is any capture bit, this is supposed to, this is should be VT. Now, if we look at the morphological pattern, because we cannot see the concordance in the V1 to V6, we'll have to go to the characteristic number 2, which is the Brugada sign. So in any lead, if you consider from the beginning of R wave to the nadir of the S wave, it's almost 200 millisecond, which is well above the baseline of 100 millisecond for Brugada sign. I cannot see any obvious P wave in these segments, so it will be difficult to demonstrate the atrioventricular dissociation. With regards to the morphological pattern, you look at the V1 or V2, the RS ratio is more than 1. In V6, I can't comment because there is no, there are some ventricular ectopic, but can be difficult to demonstrate that. Characteristic number 4. So let's do another one. So this is another patient who has got a white QRS complex and it is regular. And if we try to consider the characteristic features of Brugada criteria, the first criteria is the presence of concordance in the precordial leads. Now, if we look at the QRS complexes in V1, V2, V3, they are predominantly upstroke. But in V4, V5, V6, predominantly there's a downstroke. So there is no concordance. So we'll go to the Brugada criteria 2, which is Brugada sign. So from beginning of the R wave to the nadir of the S wave, that is almost 200 millisecond. So this needs to be a VT. I can't see any obvious P wave, so it will be difficult to comment about the atrioventricular dissociation. But if we look at the morphological characteristics, in V1, there is RS ratio is more than 1. So there's a big R wave followed by a small S wave. And if we look at the V6, there is a small R wave followed by a big S wave. So the RS ratio is less than 1. So this is one of the morphological characteristics of VT. So on the basis of the Brugada criteria and conventional criteria, we can diagnose VT pretty confidently now. Now, let me summarize the management. Once we do the diagnosis, we can divide these patients into 3 broad categories. One is a cardiac arrest, and in this case, we need to follow the ALS protocol. If there is no palpable pulse, we will give a unsynchronized DC cardioversion with 200 joule and follow the protocol, do the CPR every 2 minutes. If the patient is unstable, then we can do synchronized DC cardioversion following sedation. Now, this should be very clear what is unstable meaning. Unstable meaning 4 things. Either the patient has got a systolic blood pressure of below 90 millimeter mercury, or there is chest pain or acute coronary syndrome, or there is reduced level of consciousness, or there is pulmonary edema or left ventricular failure. If any of those 4 characteristic features are present, we call this unstable VT. and the patient is treated with synchronized DC cardioversion. They will need sedation and they will need analgesia. The third category of patient is stable patient. They are awake, they can communicate, they have got normal blood pressure, no acute coronary syndrome, no chest pain, normal GCS, and they don't have pulmonary edema either. So these are the stable patients. We can treat them with chemical cardioversion, such as amiodarone, procainamide. There are a lot of different options. In any of the cases, we need to consider the cause and treat that cause. For example, if the patient has got acute coronary syndrome or MI, they need to go to cath lab for catheterization, or they might have to have a stenting. So that is the main treatment option in case of the VT, cardiac arrest, unstable patient, and stable patient. So there are some controversy with regards to the Brugada criteria. There are some of the clinicians who feel that the Brugada criteria probably is not good enough. There is a recent paper which is published in 2018. It's a meta-analysis on the basis of the Brugada criteria applicability in the broad complex tachycardia, mainly in case of the VT. And the authors found that out of the almost 2000 ECGs in 13 different studies, the sensitivity is pretty good with regards to the Brugada criteria, 92%. So we can rule out VT if the Brugada criteria are not fulfilled. However, the specificity is only 71%, which means there is a moderate specificity. So we can probably rule in with Brugada criteria, but we'll be more comfortable in ruling out VT on the basis of the Brugada criteria. The authors suggested that the Brugada criteria are excellent tool for the diagnosis of the VT and to differentiate VT from SVT. So the Brugada criteria can be quite complicated, but if we practice this once again and again and again on real life and in patients and in the ECGs, it does not feel like that complicated. There are only 4 steps, and if we use these 4 steps, and of course we need to consider what are the underlying different conditions, and many of the patients are admitted to cardiology for AICD depending on what the underlying conditions are. Now let me summarize the whole topic. So obviously we need to consider the demographic characteristics of the patient, below 35 or above 35, underlying cardiac disease, ischemic heart disease, cardiomyopathy. With regards to the ECG criteria, we have talked about the conventional rules like presence of fusion bit, capture bit, the atrioventricular dissociation, white QRS complex, northwest axis, concordance of the QRS complexes, and the presence of the left taller revitier in V1. That is conventional ECG criteria for VT. With regards to the Brugada criteria itself, there are 4 steps. First criteria is look at the concordance in V1 to V6. If that is present, this is VT. If the concordance is absent, then look for the Brugada sign, which is from the beginning of R wave to the nadir of this wave. If it is more than 100 millisecond, this is Brugada sign, this is VT. If not, go through the step number 3, which is atrioventricular dissociation. If atrioventricular dissociation is present, this is VT. If atrioventricular dissociation is absent, then we'll go for the level 4 or step number 4, which is the morphological characteristics. One of the morphological characteristics is V1 RS ratio more than 1 and V6 RS ratio less than 1. The other morphological characteristic is width of the R wave in V1 more than 30 millisecond, or there is a slurred nosed S wave in V1. Of course, in case of the white complex tachycardia, always think about toxicology like tricyc antidepressant, carbamazepine, propranolol. They are not VT, they are VT mimics. In case of hyperkalemia, they can also cause white complex tachycardia, and we need to be very careful before we give treatment. If we give amiodarone in a patient who has got tricyc antidepressant overdose or hyperkalemia, they can develop VF and can eventually die. So we need to be very careful about that. In any wide complex tachycardia or VT, whether we use the Brugada criteria or other conventional criteria, we need to try to identify the cause of it. Is it myocardial ischemia? Is it electrolyte abnormality? Is it cardiomyopathy? Depending on the cause, the appropriate treatment should be provided. So there is some very good articles in Up to Date, and also Ed Burns have got fantastic resources in Life in the Fast Lane. So they can be used for further references. If you've got any further questions, please drop me a line. I'll be happy to answer. Thank you very much for watching, and I'll see you soon. Bye for now.